How's it going, everyone? Welcome back to the Rehab Science Podcast. I'm your host, Dr. Tom Walters. In today's episode, I'm really excited to talk to Dr. Emily Splichal, who is a functional podiatrist based in New York City. Dr. Emily has a really cool approach that is, I think, really different than most podiatrists you'd run into. So, really excited to talk with her. Dr. Emily, thank you for coming on the podcast today.
Of course. Thank you so much. I'm excited to chat with you.
Totally. I was telling you right before we got on, I have seen, you know how the algorithms go. You see people for a while and then you don't see any of their stuff for months. But I've been following your content for a number of years, and it's pretty obvious right away that you function differently, very differently than most podiatrists. Patients that I have come in who go to see podiatrists, usually it revolves around orthotics and surgery. I think in most cases, medication, things like that. But for the listeners coming in, some will be practitioners and will understand podiatry. Some will be patients and maybe haven't had any experience with that profession. Can you give us an idea of what podiatry is, just kind of at its root level?
Yeah, absolutely. So podiatry is, we actually go to our own medical school, you could say. So it's taught very much in the same route as a osteopathic doctor or a medical doctor. Our initials are the DPM, so a doctor of podiatric medicine. So we do 4 years of podiatric medical school, and then that's followed by a mandatory surgical residency, which is important for professionals and patients to know that that's why sometimes there's a frustration in podiatry, like modern day podiatry, that everyone is pushing surgery, because that's really what we're taught primarily in that residency, that mandatory residency, which is 3. And I think now they actually have 4 years that you could do 3 to 4 years of surgical training. Very early on, even when I was going through my surgical training, I knew that that was obviously not the only answer.
Yeah.
But I see why people see surgery when a patient comes in, and I have to consciously not do that. And now I don't do surgery anymore. I actually left surgery in 2017, that I can fully obviously look at something from a functional perspective without that lens of forced surgical perspective.
Mm-hmm. Yeah, I didn't realize so many residencies, even when you think about MDs, they can come out as just like an internist and not necessarily do. I didn't realize in podiatry you have to do it's a mandatory surgical residency.
It is, yeah. We're actually under surgery. So in the hospital, of all the different departments, they're like, where's podiatry? Podiatry is actually under surgery, and that's what we're considered. So we rotate with all the other surgeons to really just perfect our skill of being in the OR.
Yeah, that's interesting. And you stopped performing surgery in 2017, you said?
I did, yeah. So I put down my blade for the last time in 2017, which I was never really passionate about surgery. I have friends and colleagues who just thrive on being in the OR and just using their hands in that way. My brain works different. I would rather be a detective of human movement.
Yeah.
But being in the OR, it pays really well. Obviously, it's its own skill set. It's fun if you think of that. But I knew that how I approach patients, if you want to be good in the OR, you have to be in the OR, which means you have to push these patients and you have to do surgery. And the gap between my surgical cases was becoming larger and larger. I was traveling a lot around the world, spending half the year not even in the US. So I was like, I'm losing my skill. And if I'm not keeping my hands wet per se, then I just cannot do that morally to a patient.
Sure.
And do that. So that's why I put my
Yeah, that makes sense. I would imagine you have to get a lot of reps and you've got to keep getting the reps in to keep that kind of that skill set, that almost like that motor skill set up with surgery.
Yeah.
I'm so much like you. I really disliked seeing post-surgical patients when I was seeing a lot of patients because it felt very monotonous and there wasn't a detective hunt. I've always enjoyed the person who has pain, but they don't really know why. And so I've always just enjoyed that process of getting to know them, their story, knowing how complex pain is and all the factors that can go into it, looking at their movement system and really trying to go through that kind of process of exploring their situation and what is the primary, what things are contributing to the pain they're experiencing. I just think that for me was always more exciting than just I've had an ACL reconstruction and the surgeons got this protocol and we're just going to follow it. So that's cool to hear that that's kind of where you're coming from too.
Yeah, I try to encourage the younger generation of, like, let's say podiatry, because
Yeah.
that's obviously where I'm at, that let's say every heel pain that comes in, like, here's another plantar fasciitis, that I try to bring an excitement to every presentation and just be like, I wonder, like, why that foot, not that foot? Why
Hmm.
for them, right? Why this, that? To just be curious and keep the excitement. And then at heart, I'm an educator. So I
Hmm.
just see every patient as this person that I can educate. And I'm like, look how fascinating your foot is. And then they see it. But otherwise, a lot of professions, unfortunately, can be like, here we go, another ACL, another low
Totally.
back pain. So you have to
Yes.
keep that excitement.
That's so cool that you come at it from the, I mean, you can just instantly talking to you, see the kind of educator kind of energy come off of you and the curiosity. Did you always know that you were interested in education, or is that something you learned as you got into practice?
So I went to 13 years of school. This is outside
Long
of
time.
high school. So I am a professional student.
Yeah.
And when I finished all my training, residency, etc., and I was starting private practice, I was very much like a fish out of water because I was so used to academia type settings that I then found that what satisfies my soul is when I am teaching.
Hmm.
And so that's why I founded my education company. It's a
Yeah.
fitness and health professional education company, and that satisfies the academia need that I have
Yeah.
within me. Um, so it was a little bit by chance, but also deep exploration of, okay, which aspect of my day really satisfies me, and it's either when I'm moving,
Hmm.
which is
Totally.
why I love fitness,
Yep.
or if I'm doing something academic and delivering content and reading a research article, but then spinning it and rewording it in a way that a patient could understand it. That's satisfying to me.
Yeah, you and I are so similar. I mean, from both the fitness side and I taught kinesiology to undergraduates here where I live for 10 years. And I knew just after a couple of years of full-time clinical practice that my favorite thing was the initial evaluation with the patient where there was more education.
Mhm.
And I just knew I always felt called to education. I was did martial arts in high school and taught martial arts and kind of thought I'd go that route instead of going to college. I just opened a martial arts school, but I didn't realize until later on when I was teaching undergrads, we had went through this project, kind of this test, this personality test to figure out kind of where your passions lie. And it wasn't until I was teaching them that I realized, oh, it's kind of education was that variable that kind of carried through that I was really interested in. So it took me a long time to
Yeah.
kind of figure that out. I kind of knew it at a gut level, but I had never kind of consciously realized that it was the education piece. So we share so many
Love
kind of
that.
similarities there. When did you found your education company?
So that was in 2012, and my
Oh,
education company is called EBFA Global. It started as Evidence Based Fitness Academy,
uh-huh.
and then I renamed it to EBFA Global just so it's a little bit broader. But I started it because when I went back to school, so I was going through residency. I
Yeah.
didn't share this part. I was going through residency, surgical residency, and it was very conflicting to my beliefs, even though I knew I had to do the surgery route. I wanted and needed that integrated functional side. So I actually left my residency after a year. I didn't finish the other 2 years
Mm,
for a moment. I went
yeah.
back to school, got my master's in human movement.
Wow.
And at that time, the barefoot running boom was happening. So the Five Finger Shoes, Born to Run the book.
Hmm.
So I focused my 2 years master's around barefoot science.
Gotcha.
And I was like, that's going to be my way to really dive into this functional side. Again, I didn't know what it was going to look like. Get my master's. I go back to residency because I have to. That's the only way to get licensed.
Hmm.
But at that time on the side, I was starting to formulate this education company to satisfy the part of me that was education functional while completing my residency. So the start of my education company was around barefoot science,
Hmm.
foot anatomy, gait. We actually have many certifications now. We have the barefoot training specialist, pelvic balance. I'm big into interoception, neurosensory specialist. We have all these different trainings that are very much based around how we perceive our body, how we connect to our movement, how we support movement longevity, and then, of course, just heavy foot anatomy ones because of podiatry.
That's amazing. So, I mean, obviously, knew at a really early stage, I mean, even before getting out of residency, that you were going to incorporate all of this human movement, this other aspect. And it sounds like, did your fitness background weigh heavily into that? I mean, did you get into podiatry and then realize, oh, I have this whole side of me, this whole other side of fitness and body awareness and
Well,
kinesiology and,
yeah, so I was actually a competitive gymnast. That
mm,
was very
yeah,
important to the start of my story.
uh-huh.
Um, Gymnastics is amazing. I'm totally
Yeah, I was
biased.
a gymnast in high school too.
Oh, you were? Oh my God,
Yeah.
brother and sister or something. So,
Yeah.
so gymnast, as you know, or any of the listeners, if anyone was a gymnast, is just like it creates a certain level of discipline and focus and drive and just a connection to your body. It's very into fascia, body weight, barefoot, even though at that time I did not appreciate that aspect of it,
Totally.
but that's very much the sport. That was really important to the start of my story.
Mhm.
So when I graduated undergrad, my bachelor's is actually forensics, which
Wow.
explains my brain and why I love human movement because I look at it
Yeah.
like a detective. But so I was doing that. I left because I was not happy with that path. And I was like, what satisfies me? And it's something related to movement, gymnastics movement, right? So I was like, I'll be a personal trainer. That's where I got into fitness. And then fitness just lit my soul on fire as far as how satisfying it was.
Yeah.
But then I started getting hurt because I was teaching group X as well. And I was like, okay, there's no longevity into it. So
Hmm.
how do I get a graduate degree where I can combine it? And that's where
Hmm.
I went into
That's
podiatry.
amazing. That's so cool. I feel so, gosh, there's so many similarities we have, but like you know, because growing up in gymnastics and martial arts, I was always barefoot.
Yeah.
So, but I didn't appreciate at the time how much I was learning about, discipline and things like you say, but also just about kind of body awareness and just being barefoot, like the foot strengthening that came from that. Like my feet to this day still look kind of funky because of all the things I did, especially in Taekwondo with positions I would hold my foot in. Certain muscles have kind of hypertrophied, and you
Mhm.
know, it just it. I talk about this all the time now, how grateful I am for those sports because I just learned so much my motor control. I think people often comment on my videos about my movement control when I'm demonstrating exercise, and so much of it comes from martial arts and gymnastics. And I just didn't appreciate that at the time. I just was doing it because I enjoyed the sport.
Yeah, it definitely stays with you. And that's why I think every child, I think it should actually be mandatory in schools to do like dance, gymnastics, martial art, these things that relate to body perception,
Hmm.
because just the way that you carry yourself, your posture, the way that you navigate other people, just the grace at how you move. A lot of people, when I present, they're just like, were you a dancer? Because I'm like pointing my toes as I'm speaking on the stage and like, can't help it. But I think that is really, really important for the emotional side. I remember teaching group exercise and I would be, doing something and there'd be a random person every once in a while who's like on their left side and we're on our right side. And I'm like, do you not see that you are moving the wrong limb? Like
Yeah.
and I think there's just this level of disconnect that some people have because they
Hmm.
never went through those specific sports that ingrain body awareness. Now I use body awareness, or really it's called body schema,
Hmm.
when I speak about fall reduction or professional athletes and really optimizing movement. Is it's all based around your perception and your awareness to your body and space. So I'm very into body schema, which is
Hmm.
ironic that I was a gymnast in this part of it.
Yeah. Yeah. I know you talk a lot about and have a lot of focus in your company and in your teaching in sensory kind of perception and how much our ability to sense the things that, are coming from our skin and, all these different sensory organs we have and how that informs our movement control and our motor system.
Yep.
Is that when you talk about kind of this, when you think about that, you said, did you call it the body schema?
Mhm.
Is that kind of what you're thinking about, as this interaction between sensory information kind of coming in and how that informs how we move, kind of that whole loop?
It is, yeah. So body schema, by definition, you could say, is your mind's mental image
Mm-hmm.
of your size and shape in space. So your brain has this perception, and you could think of it almost like an image. And I will do a practice or an exercise when I teach, where I'll have people shut their eyes and then have them, see slash feel their head. And, like if the listeners now shut their eyes, like you can see and feel the size of your head. Like I can feel how wide my shoulders are, right?
Mm-hmm.
So it's being able to connect that mind mental picture. It really falls
Yeah.
under mind body.
Mm-hmm.
And I got into this initially because of the work that I do in fall reduction and active aging and things like that.
Got it.
We lose our mind body connection with age. It just weakens. Like
Mm-hmm.
any other aspect of the nervous system,
Yeah.
it slows or becomes weaker, or maybe it like breaks for some people, right?
Mm-hmm.
Throw in there a TBI or a concussion, throw in there a stroke, MS, extreme weight gain, neuropathy, whatever it is, something that is breaking this mind body connection. And then that's where people start to move inaccurately, or you could say fall.
Mm-hmm.
So yes, it's a dance of your internal awareness, your external awareness. Your external awareness is called exteroception.
Yeah.
That's the perception of the external space.
Mm-hmm.
Your internal awareness is interoception, and that would
Yeah.
be like your heart beating, butterflies in your stomach, things like that.
Yeah. Yeah. So cool. It reminds me a lot of, in neuroscience, thinking about kind of they'll talk sometimes it's about the sort of body map we have in our brain, sort of our virtual map, sort of like the homunculus. And I'm sure that all
Very simple.
factors into everything you're talking about. But I hear those terms, you see them sometimes: interoception, exteroception. I need to do a better job of actually going and diving into those areas. I love the nervous system, and I spend a lot of time on pain neuroscience, and all this, of course, is in there. But I haven't spent as much time kind of researching those areas that you're talking about. So when you got out and you were first started practicing, obviously you were doing some surgery, but were you right away with patients looking to, I would imagine the way you were assessing people and the interventions you were implementing were different right from the get-go from the standard podiatrist. I mean, is that true?
It was maybe initially a little bit more restricted, because I was under insurance. I was part of a large practice, and the practice brought me on because they knew that I was a little unconventional.
Uh-huh. Yes.
And living in New York City, I was doing a lot of media around it. So they kind of saw it as like, she's a unicorn. We don't know, like, really how unicorn,
Yeah.
but we just think there's some asset to it, like even if it's just SEO or something.
Hmm.
So they brought me on,
Yeah.
and yes, I would do a gait assessment on every single patient. I was the only podiatrist that would be like, come out of the room, walk down the hallway, let me do,
Wow.
I'm taking photos, I'm on the
Yeah.
floor doing it. And then I would look at their shoes. I would have this conversation. I would teach them short foot, which is my go-to foot
I love
exercise.
that
I
one.
would just start to kind of push that boundary a little bit.
Hmm.
And I was still having surgical conversations, but my surgical conversation was very respectful and highly explanatory. And I would just spend more time than the insurances really want you spending with the patient. So I
Yeah.
would get totally backed up. But I would just respect and make sure that their questions were answered. Then the other part that really changed my practice is about 10 years ago, I started doing regenerative injections.
Oh, nice.
So PRP and then amniotic based. And now I do more umbilical cord based in my office. But I
Hmm.
started doing those. And those at that time were not covered by insurance. Now you can kind of finagle some insurance coverage on them. But all the other practitioners that I was with, they were like, how are you selling these $1,000 injections to your patients so easily? And I was like, well, one, I believe in them.
Hmm.
But two, I very much explain and I say, this is the most conservative thing you can do.
Hmm.
Here's bumping it up a knot. Here's your injections. Here's surgery.
Yeah.
These are your offerings. And really, you want to kind of go through everything. Surgery should always be your last resort, right?
Yeah.
And we just honor that and say, if you have the time and money, because there's obviously a cost to these things, I would try to exhaust everything, which includes these regenerative injections.
Hmm.
And I actually formulated, and I do regenerative injections very different than really anyone else that I know, especially in my space, podiatry,
Hmm.
because I do the injection, but I take them through this 3-month protocol. And they're on a short leash and we engage every 2 weeks and I'm following them for 3 months. And I take them from immobilization to a decrease in immobilization to a reintroduction of stress in a very controlled way for that 3-month period.
Hmm.
And that's where I think I have the greatest success with patients, because I tell them this is not a magical injection. I wish
Hmm.
that all I had to do is inject you and then poof, your plantar fascial tear is gone. But I'm
Yeah.
like, it doesn't work that way. I need to guide you through understanding the pathology and the physiology behind tissue injury. And that's why I follow them for 3 months.
That's amazing. So you're starting with the injection, and then you have that 3-month protocol to really help boost the healing. And like you say, because a lot of people just get the injection, just go right back to everything normally. And
Yeah.
of course, you wonder how much effect did it really have because they aren't having. There isn't that kind of follow up protocol almost in a way to, I think, maybe kind of really help whatever potential effects could have came from the PRP or stem cell injection. Uh,
Yeah, I'm
Yeah.
very into the regenerative space. I'm very into anti-aging medicine as well, or
Hmm.
longevity medicine, people
Yeah.
refer to it now. I just think that there has to be a true understanding, a curiosity, a respect for this space. And I find that unfortunately there are practitioners who don't understand, and their regenerative injections could be just a
Mm.
moneymaker, right?
For
Like
sure.
get
Yeah.
right, kind of like orthotics, right? Orthotics, you
Yeah.
make a lot of money on them. So if you can just push them, but not really understand it, then eventually it starts to damage the reputation of the intervention because you're not respecting it. And I think that it needs this whole supportive protocol around it. I'm
Hmm.
very into photobiomodulation at the same time.
Yeah.
I'll have patients either do aggressive, like Graston dry needling shockwave, then come to me, do the injection, and then I take them through the protocol. So it's really seeing the whole story of what it is.
Yeah, that's really cool. Um, so many things to think about there. When the PRP and stem cell side of things, what diagnoses do you find that to be most helpful with? What are you using it for most of the time?
Yeah, so in podiatry, obviously, because it'll be
Yep.
foot
Yes.
specific,
Yep.
is I see a lot of partial tears of the plantar fascia.
Hmm.
And what's important for the listeners just on this, because I see a lot of it, is our plantar fascia, as most people probably know, there's 3 bands, right? We have a medial, central, lateral. The central band also has 2 layers. So it has superficial and deep. When people get partial tears of the plantar fascia, it's typically central band, but it's going to be either the deep or the superficial fibers.
Hmm.
So that just kind of visualizing the chaotic, frayed presentation of that is why I really look at regenerative injections. So that's one of the most common that I'll do.
Got it.
The other one is plantar plates.
Mm.
And the plantar plate is under the second, it's an extension of your plantar fascia. It acts like a ligament, and its job is to pull the toe down. So it's an anchor or a stabilizer of your digit. The second is the one that's most commonly stressed, especially if you have a long second toe.
Hmm.
And typically, how it presents is people will have a partial tear. So it's not a total rupture of the ligament, it's a
Hmm.
partial tear, kind of fraying on one half of that ligament.
Hmm.
Very high success with that.
Hmm.
And then I've done other ones like intersesmoid, MCL, and some of the collateral ligaments of the first MPJ. I've done that on a lot of individuals. You can do them to the post-tib, perineal, etc.
Hmm.
But the 2 big ones that I see in my office are plantar plate and plantar fascia.
Hmm. And do you, I know I see more and more research supporting PRP and stem cell for the reduction of pain. Are you, with your protocol, seeing healing of those tissues? I mean, are you looking at imaging and tracking it, I'd imagine? And yeah,
I do, yes. I do not do a repeat MRI. So I don't do any injection without an MRI.
got it.
Ultrasound, sure, that might guide it, but I will still always do an MRI before doing any of the injections.
Yeah.
On some patients, I will do a repeat MRI 3 months later, 6 months later.
But it's
Not
mostly
all.
tracking symptoms and function and seeing how they're
Yeah, so
doing.
I
Uh-huh.
would much rather track symptoms and
For sure.
function, right?
Yes.
And I'm very straightforward with these. I do not believe in misguiding patients. I try to be very real with patients. And I
Hmm.
say, "Hey, the way that you're presenting, if I could get you 50% better, 50% from where you are right now, is that a success to
Hmm.
you?" Right? Like, let's get on the same page here. Am
Very
I
transparent. Yeah.
take your 50-year-old plantar fascia and make it like you're 20 years old again? Well, that's not realistic. I need
Sure.
to be realistic, right? But if I can take it, and most of my patients are very athletic.
Mm.
Right now, I'm treating a patient that has a frayed peroneus longus tendon at its insertion and was
Mm.
just told by all the other providers, like, you cannot play tennis ever again. You have to completely change your lifestyle. He's 45 plus years old, like around that. And he's
Mm.
just like, I can't, like, that is part of my
Identity, who I
mental
am.
sanity. And I
Oh,
was like,
yeah.
I get it. I was
Mm.
an athlete. I need to move as well. I totally get it. I get the mental health side of it. So we're doing the injections, and I'm saying, if I can get 50% more integrity to that tendon, I'll
Hmm.
have to put him in orthotics after, but can I get you in a place that you can play tennis again?
Hmm.
Not as aggressively, but can I
Yeah.
get you playing tennis? Right. So
I love
that's,
that. I love the honesty and not just that this is going to be some magic fix because sometimes those injections are advertised like that, that
you know,
so that's amazing just to have that transparency and honesty in your communication and education with patients. Um, I know you mentioned orthotics just now. So you still will use orthotics with certain people because I know you come from a lot of because sometimes the other side of that too is like people who come from kind of the minimalistic barefoot kind of this movement side sometimes will be like, I never do orthotics. So it just sounds like you have more nuance to how you approach things.
yeah. So I absolutely love minimal shoes, training barefoot. I would love to get everyone into a very minimal, natural footwear or shoe as possible.
Hmm.
However, I also understand, chronic foot presentations. And if someone has a torn spring ligament and their midfoot dropped and they have a tear in their post tib, that's actually contraindicated, and they have pain,
Hmm.
right? So I can't say, well, the reason why you have pain is that your feet are weak because you've chronically been in shoes. I need you in that minimal shoe to then re-strengthen your foot and to get you back to here.
Hmm.
That's not possible.
Yeah. Yeah. Yes. Yep.
Right? So I need to be very transparent. I need to honor the application of all of these.
Hmm.
I try to go as natural as much as I can. But if there are these outliers, these conditions, and that's actually the patients that I see, because it is confusing to everyone on the internet and things like that, is they
Sure.
say, well, I heard that I could build an arch in my foot by strengthening the foot muscles, which is true, but it's certain types of feet that you can do that. And
Yeah.
if they don't know that their foot type is actually ligament lax,
Hmm.
and they have a very lax, maybe even torn spring ligament, like I said, it's a ligament, for the listeners, that's directly under the arch. And if that tears or is lengthened, you cannot muscularly override that.
Yeah.
And I've had patients spend a year committed to training their foot, to strengthen their foot, like dedicated. And then they come to me and they're like, oh my God, Dr. Splichal, I've been spending a year. And I look at their foot and I was like, well, I could have told you right.
Yeah. This wasn't gonna. Yeah.
You're not going to change your foot type. But
Hmm.
what I will tell patients when I work with them is I say, I am going to train you to strengthen your foot, to be quicker, to stand longer, to walk more efficiently, to not get tired when you walk. But our outcome that we're looking at is not your foot shape.
Yeah.
We are not looking at your foot shape. I'm not measuring your navicular drop and how that's changing. That's not the outcome. It
Mm-hmm.
is, how do you feel? How do you feel? How do you move? Right.
Mm-hmm.
So I think just that step for the patient or the individual to actually say, okay, what am I tracking? What's
Mm-hmm.
considered success? And building a arch in the foot shouldn't be the outcome necessarily that people are going after.
Yeah, that's amazing. That's why it's so important to see a specialist like yourself who, because unfortunately people often have this perception that doing exercise will change the posture of their body. And I think sometimes that maybe that can happen, but in some of these where you have a ligamentous injury, you have this damage to a passive stabilizer like that helps support the arch of your foot. If that's torn or lengthened, like you say, you could do all of the neuromuscular control and strengthening exercises, and it's probably not going to change the shape of your foot. And maybe it doesn't really matter, like you say. I think sometimes we get so focused on that, like, what is my posture and how does it look? Can I change it? And we lose sight of kind of symptoms and how am I functioning. And so it just, I love hearing you talk about this because you're such a specialist in this area and you bring that nuance to this area that sometimes, on the internet, you just can't appreciate. That's why these kind of conversations, longer
Mhm.
form, are so amazing. I'm learning so much just hearing you talk about it. So,
Yeah.
um, when you think about a patient coming in, what would your assessment look like? And I know this is kind of a broad question because it depends on the diagnosis and what direction you go, but what does it look like for you these days if somebody comes in? I saw on your site you treat a lot of lower quarter disorders. You're not just a foot person, like somebody could have IT band syndrome or things farther up the kinetic chain. And I know you perform certain movement assessments, but can you give kind of an idea of what that would look like for you?
Yeah, absolutely. So what's important is that I am not under insurance anymore.
Uh-huh.
So I am what's considered direct access. So
Yeah.
it's not even really out of network. I'm just like not under insurance.
Yeah.
So what that does is that allows me to spend an hour with a patient. So I have an hour, and one of the most important parts of that hour is the beginning, where I'm actually listening to the patient.
Yeah.
And mind you, most of my patients now are actually virtual. So
Mm.
majority of my patients I see all around the world via, the laptop.
Yep.
So it's very important for me because I can't touch the patient. I can't move and manipulate the foot or palpate it the way I would if they were in person. So listening to the patient is very important. Listening to the history, the presentation, me knowing how to ask questions. And I think that's kind of the lost art of medicine in a way,
I
especially Western
agree.
medicine. We become
Hmm.
very diagnostic or imaging based, like, I don't know, just to order an MRI, get an
Yeah.
x-ray, stuff like that, where I try to, so let's say someone's having pain in their foot
Mm.
and it's just in the bottom of the foot. Unknown, is it the plantar fascia, is it a tendon, post tib, pronatus longus, what is it, right?
Mm.
Is I will really probe and say, at what point of the gait cycle do you feel it? Is it foot contact, single leg, when you're pushing off? Okay. How are you going upstairs, downstairs? How are you barefoot versus shoes? How about that shoe versus that shoe? Like, I really push them because there's a reason behind any of those answers. If they say, yes, it's this phase of gait, or yes, it's when I'm barefoot, or yes, it's only when I'm in shoes,
Mm.
that's actually telling me as the detective of how all of these different things are affecting foot position.
Mm.
And then if you understand the way that the foot goes through the gait cycle, it's essentially telling me without me palpating how they're presenting.
Hmm.
Understanding a lot of the type of pain, burning, radiating, etc. And then I will do an assessment. I will do a standing assessment. This is obviously virtual.
Hmm.
I'll do a gait assessment. Sometimes I'll do a squat, overhead squat, single leg, balance, step ups. So I'll take them through things to kind of further guide what I'm trying to rule out in my
Hmm.
mind.
Yeah.
Um, and then sometimes I will do where they're seated and I'm looking at their foot position, because there's
Okay.
open chain, non-weight bearing, passive positions the foot could fall in, or the hips or the knees. But I'm always thinking of foot to pelvis, well, actually rib cage to here, from toe to tongue, let's say,
Yeah.
is what I'm looking at. I will look at posture. I'll look at T-spine. I'll look at the pelvis, the way that the pelvis moves. And I think having a deep appreciation of how the rib cage, pelvis, ankle, foot influence each other,
Hmm.
I can almost just deduct that if someone is moving with a locked T-spine,
Hmm.
that it's going to affect their foot.
Yeah.
So part of my approach has to be unlocking the T-spine when I'm addressing the foot.
Yeah.
Otherwise, it just feeds into the other.
Gotcha. Yeah, it's like you say, I totally agree. That subjective listening to the patient is such a lost art. I think there's so much, I always say, because I'm in physical therapy, I always tell people just how much of physical therapy is sort of almost like talk therapy in a way. And a lot of it is not me talking, it's actually listening to the person's story because you get so many important details from them giving them an opportunity to be tell their whole story in one sitting. And I'm like you, where I'm all cash based in an hour minimum with each person. And I think a lot of patients will say, I've never had an opportunity to tell my whole story in one sitting. And I think you learn so much letting someone talk. They almost are getting a chance to process and learn themselves what might be contributing or what started this issue. And I think you need that time to be able to peel back the layers. And if you don't spend time doing that, you can go a particular direction and then realize down the road that maybe it wasn't the right direction, or you could have been more efficient if you had spent more time up front. And so that's so cool to hear that you, again, we think kind of similarly. And you hear more talk about this now, I think, in rehab in general, just how important listening and spending time with people. And unfortunately, a lot of the healthcare providers are in insurance based models, and they just,
Mhm.
it's, they don't have the time to do that. So,
Yeah.
but it's such an important piece when you, and the same during COVID, I was kind of switching, saw a lot of people virtually, and it is tricky when you can't be in person or palpate someone, but it is amazing how much when you listen to them and you have a video and you can watch them move, how much you can still accomplish without them being right there in person in the clinic.
Yeah, 100%. And I'm a big advocate of virtual or telemedicine, I guess, if
Yeah,
you would
yeah,
call it.
yeah,
There are a lot of people on the podiatry side that have a loud voice who are trying to say that you cannot do podiatry virtually, that it's a palpation based one. One, I
yeah,
think you just have to evolve with the times.
yeah, yep,
Just either you do or you don't, and you're like left in the dust if you don't.
yep.
But the way that I treat, the way that you treat, when you have a niche or you think outside the box, I want to be accessible to someone who doesn't have a provider who may be looking at the foot a certain way. I'd mentioned that I see patients all over the world, and
Mm,
I see patients in countries that don't have podiatry.
yeah,
So to me, it's really important to be able to help people regardless of where they are in kind of their state of the country they're in and the healthcare system.
yeah,
But yeah, it works really good. And the one thing that I love about it, because I believe in it, is people have to take ownership of their own body. Where I'm
mm,
like, I'm not going to heal you, meaning
yeah,
I'm not going to be the body worker. So I'm not a body worker. I don't
hmm,
do anything as far as
like
uh,
manual therapy kind of stuff.
yeah, I'm not a
Yeah,
manual therapist.
hmm,
Um, that they have to take ownership of their health and this
hmm,
protocol that I'm giving them. So I give them their protocol in
yeah,
a way that they have to do it 1 to 2 times a day. It's a, whatever the series is, but they have to do it to themselves, knowing that even if they went to a traditional manual therapist, they're not going to go every day
hmm,
to it. So we
yeah,
still have to do something that is, and I know you do this with your patients, that
hmm,
it can't be just your time that
yes.
they do the exercises and things like that. They have to be an advocate or a participant in this process as well.
Yeah. Yeah, I agree. And there's so much research to support those active interventions, which are, to me, are what people are doing outside of the session. Because I will use some manual therapy. It's reduced over time. And I think, manual therapy in certain situations, certain diagnoses can help in the short term to kind of get people maybe out of some of that acute pain so they can get to some of the movement. But at the end of the day, the things that they do for themselves, I would rather there's more research to support those things. And I think at the end of the day, your goal is to boost self-efficacy in people and teach them how to self-manage. And
Yep.
you're doing so much that I think it's so cool that the idea that you're giving access to people in other countries where they don't have podiatry, because I think that to me has always been a huge positive of social media over the years. Is I will interact similarly with people who don't have access to physical therapy or it's too expensive in their country. And I think as much as we talk about the negatives of kind of the online space, that is a huge positive. So I can imagine all these people that are getting podiatry, even probably more so than physical therapy. I imagine there's a lot of countries where there aren't podiatrists.
Yep. Yep.
Yeah.
Yeah, and that's a big reason why I created. So I have some at-home foot programs,
Uh-huh.
which are kind of guiding and saying, I understand if you want to stay under your insurance or my fee is just like out of budget right now, totally respect it. So I have a 6-week protocol where you could, for your plantar fasciitis, again, I'm not saying if it's acute or chronic because I'm not
Sure.
involved in that. You are making this own
Yeah.
decision on yourself, but I will guide you the way that I do guide patients
Mm.
through this plantar heel pain story. And
Yeah.
then if you go through it at your own disclosure or your own
Mm-hmm.
discretion, you do
Yeah,
it and you still have pain, I would just highly consider doing a consult so that I can actually see what's going on.
for sure.
Okay, so
What types of conditions do you have programs for? So you have the plantar fascia heel pain. What other ones?
Yeah, so I have 3 right now. I
Uh-huh.
have bunions,
Uh-huh.
huge one, bunion, big toe,
Yep.
plantar fasciitis, and then just a general flat feet one, which could of course go to like post tib,
Post tib. Yeah.
perineals, right?
Yes.
Achilles could probably go under the plantar fasciitis one.
Yep. Yep.
And then I am doing a neuroma one because that's a
Oh, nice.
huge one that people have a lot of
Yes. And a
questions on.
challenging issue. It's
Yes,
yeah.
that one I'm working on an Achilles and then an ankle sprain.
Okay. Yeah, it's true with the plantar fascia. I feel like so much of the exercise-based kind of things that are used now could also help with Achilles, a lot of the different calf raise variations. And we see these ones with the big toe and dorsiflexion now where you're loading, trying to load the plantar fascia more. You mentioned bunions. What do you think about, okay, so one question I see these toe spacers all the time. How do you feel about toe spacers for bunions?
Well, so one, I am obsessed with toe spacers.
Nice. I need to
Just
try
like
some.
everyone else on the
Yeah.
internet is
Yeah.
obsessed with toe spacers. But so I love toe spacers and I've been recommending them for years. This is before Naboso
Uh-huh.
started selling them, where it
Yeah.
was one where I was like, if I keep recommending these all the time, I might as well sell them
Exactly.
and then improve them a little
Yeah.
bit as far
Yep.
as the ones that we sell. But so the way that I look at toe spacers for bunions is we can think of it as something that is supporting the natural toe alignment. So if you have a
Sure.
bunion, it's going to pull it into a more natural, aligned, centrated position,
Mm.
which is going to protect the joint.
Sure.
But it's protecting the joint and the alignment when you're wearing the toe spacers.
Yes.
So that is important. Now, bunions are progressive, which means every time you take a step, you essentially make your bunion bigger, even if it's very slowly, but you are making your bunion bigger. So toe spacers really are intended to be used when you are walking around in your shoes, if you can fit them in your shoes, when you work out, things like that. It's also a really great way to recover your feet. So maybe they don't fit into your shoes. You can wear them at the end of the day and kind of stretch out that bunion or just your feet in general.
Mm.
But they're not intended to reverse bunions. That's the
Yeah.
one thing that I will be very straightforward on that as well. And I do see stuff, unfortunately, online saying I can reverse your bunion. That is very unfair to the patient to tell someone that you can reverse a bunion.
Mm-hmm.
One thing that I will say on that, because there might be some listeners who are saying, but I reversed my bunion with toe spacers and exercises, is I have my hand, and if people are listening just to the audio, but a bunion is essentially the metatarsal swinging out, and then you have the toe coming this way.
Yep.
That's the bunion, is the swinging out of the metatarsal to create the bump.
Yep.
The angulation of the toe that's pulled in by your adductor hallucis,
Mm.
that's not really the bunion.
Got it.
So what
Yes.
people do is they'll use toe spacers or they'll do exercises or they'll stretch it, and they'll pull the toe straighter
Mm-hmm.
away from the second, if people could kind of visualize this.
Yeah, big toe is pulling away from the second toe.
Yes, but the
Yeah.
angulation and the opening of the metatarsal is still there.
And that's the bunion. That's truly the bunion, is the metatarsal angle.
Yes. So
Mm-hmm.
this is just a case of like an optical illusion in a sense that you didn't really close the space between the first and the second metatarsal.
Hmm.
That's why when I do a bunion assessment, I have to look at x-rays. For
Got it.
me to be really thorough, I cannot give you a full recommendation, a functional recommendation, and a uh, explanation of the future of your bunion and what your joint looks like and your risks and all of that without looking at x-rays.
Mm-hmm.
I
You have
also
to be able to see that metatarsal angle. Is that what you're looking at? Yeah.
Yes. And I have to look at the joint space. Are there any spurs? Is there joint space narrowing? Just like what's happening in that first
Mm-hmm.
MPJ or the big toe joint. And then one thing that I will say, because I see this quite a bit, is to look at your foot statically and look down and kind of, I'm sure you can manipulate your toe and pull it a little bit
Yeah.
straighter as you're just standing there.
Yep.
Totally different. As soon as you start walking, like in the most respectful way, I know that toe is going right in.
You got it.
And so there's something about static versus dynamic. I watch gait all day, and I know that toe is slipping
Mm-hmm.
back into the bunion in your shoe or when you walk around, unless you have that toe spacer. And this is even if statically sitting there, your toe looks straighter, like you reversed your bunion.
Hmm.
And like
Yeah.
not to be a Debbie Downer on that, I just want people to have a full understanding
Yeah.
of things,
Yes.
just so we're using the right words and we
Yeah.
really understand what's going on and the future progression and the joint health of the bunion.
Yeah. So even if really maybe you work on your big toe dorsiflexion mobility and you work on your ability to use your muscles to pull it back out, doing that statically is totally different. Once you start walking, people can't, even if you really thought about it, you're not going to maintain it. And that's where a toe spacer could be really useful.
Yes. Yeah.
Hmm.
There is also a product called Bunion Booty. I
Mm.
have no affiliation with them, but it's called Bunion Booty. And it's a little like a sock. It slides on the first and then it hooks around the back of the foot. Really, really easy way to get the alignment of the big toe without like a bulky toe spacer. So depending on the shoe, it's just
Oh.
another option. And their website is bunionbooty.com.
Hmm.
And
And what do you do? We could do a whole episode on these different diagnoses, but when you think about maybe some of the exercises or strategies you teach people to kind of self-treat their bunion or to work on it, what kind of things would you teach someone?
so bunions are highly associated with medial column instability, or the
Hmm.
whole inside of the foot is unstable. Now,
Hmm.
is the inside of the foot where that metatarsal swings out, is it unstable because the foot is weak? Is it unstable because of ligament laxity? Is it unstable because you have limited ankle dorsiflexion and you're compensating by unlocking the rear foot? I don't
Mm-hmm.
know,
A
right?
lot
So
of, a lot of,
you're
yeah.
gonna have to go in there, but there's some level of instability or breakdown along that medial side of the foot, medial arch into the rear foot, that is predisposing or accelerating bunions.
Hmm.
So, having said that, if you want to prevent bunions or slow the progression of bunions, you have to look at the rear foot. This is not a big toe or a forefoot issue. It's a rear foot / midfoot issue.
Hmm.
So I will teach people, if they do have a unlocked foot, okay, this is how I find neutral. Whether it's because of ligament laxity or muscle weakness, why
Hmm.
I collapse, doesn't matter. Right now, I just need you to feel what neutral feels like. And
Is
then
that like a subtalar neutral? Like you're helping them find that? Yeah.
I'm
Yeah.
just
Yeah.
going to have them externally rotate their tibia to
Yep.
lift the navicular, and now they're in a
Yes.
aligned position.
Mm-hmm.
And can they hold their foot there when they brush their teeth, when they do dishes, right? So can we just start with an awareness?
Sure.
So that's the first part.
Yeah.
Then it is strengthening the foot stabilizers. Short foot is one of my favorites.
Yeah.
Posterior tibialis, putting a ball between the heel and doing a calf raise.
Yes. I love that one.
Strengthening foot to core, getting into your glutes, single leg exercises. So
Mm-hmm.
you're doing these different exercises to get the foot intrinsics, the arch stabilizer, which is your posterior tibialis,
Yep.
the deep core, and then your glutes. And those
Yeah.
are all responsible for the foot.
Well, and you can totally that whole line of thinking, you can imagine how that would apply to plantar fascia,
Oh,
posterior tibialis, like Achilles, almost every lower quarter, like getting to single leg, incorporating your glutes, just how this whole kinetic chain is all hooked together. Can
yes.
you explain that short foot exercise? How do you cue that?
Well, yes. So the first way that I like to teach short foot, which is kind of a newer way that I do it now, is through what's called a forward lean.
Hmm.
And so I'll have people, and if the listeners want to do it when I'm doing it, you can stand up. Your feet are shoulder width apart. You want to find your foot tripod. So first, fifth heel, lift the toes, spread them wide, and then do just a little rotation of the hips so you can lift the arch. We'll just leave it
Uh-huh.
at that right now. Stay like that. Imagine that you are stiff as a board. So you're standing nice and tall, stiff as a board. Stay exactly as you are. And then you're going to lean your body forward, kind of like a ski jumper would lean forward,
Okay.
and then come back vertical, lean forward, come back vertical. And you're staying stiff as a board the whole time that you're doing it. So you don't flex at the hips.
Mm.
Every time you lean forward, what you should feel in your toes is that they anchor.
Yeah.
So this anchoring mechanism, that's really what short foot is. So I just
Hmm.
want people to connect to it. Forward lean is one way to do it so that the patient or the individual is like, yes, okay, I feel that the tips of my toes have this action. Got it. Okay. Can I now do that action without leaning forward? So I'm standing nice and tall. Okay. Push my toes down, anchor them, no lean. Got it. Great. Okay. Now let's actually integrate that because short foot is integrated. So the integration of the foot with your core and your diaphragm is based around an exhalation. So every time your toes anchor or push down, I want you to exhale. That's the stack or the integration you could think of. So I will have people inhale into their belly, and then slowly start to exhale. And as they are exhaling, they're starting to push their toes down into the ground. And we keep exhaling, and then we relax everything, and then inhale into the belly, and then exhale, let's say 8 seconds. As you're exhaling, push the toes down, keep exhaling, and then relax everything. That's the
Hmm.
first integration.
Yeah.
Second integration is that it's actually incorporated deeper into the pelvic floor, and it's specifically with your posterior pelvic floor, which is your levator ani.
Hmm.
So as your toes go down and as you're exhaling, theoretically, you should be putting attention to lifting your levator ani. And yes, the whole pelvic floor, but it's actually a little bit heavier into the posterior pelvic floor. So same thing, inhale into the belly, you're going to exhale. And as you are exhaling and as you're pushing your toes down, you're going to start to lift the posterior pelvic floor as you are exhaling. So this is creating a sinusoidal type wave of an integration or an activation.
Hmm.
That's 8-way. Ultimately, this stack of toes down, pelvic floor up, exhale, is in a squat. So let's say I'm doing a back squat, I'm loaded up, I'm going down into the squat. As I'm at the bottom of the squat, I'm going to anchor my digits into the ground and I'm loaded. So this
Hmm.
is obviously a little bit more dynamic,
Yeah.
but I'm pushing my toes into the floor, lift my levator ani, and I'm going to push out of the squat, exhale as I come up. But it's led through this foot to pelvic floor anchor or
Hmm.
connection. And then I use that anchor for stability. And that's what I exhale and I drive my hips out of that. So that's
Wow.
essentially a way that you could do it. There's many, many ways of how to integrate it.
That has so many more intricacies than what I had known about it before this. So that is, I love the forward lean because when you're just trying to cue people to just kind of contract their foot intrinsics, sometimes people just they don't have any idea. So
Yeah.
I love the idea of the forward lean and just everything you've been talking about, kind of that just beginning to become aware of what's happening. And that's such a easy way to create movement somewhere else in the body that's just going to force those intrinsics to come on, and then people can start to become aware of it. So that's such a neat, because previously to this I would just kind of cue people almost to just try and almost kind of scrunch their foot and create almost like an abdominal contraction of
Yep.
that kind of deep core of their foot.
Yep.
But sometimes people just can't figure that out, or if I show it in videos, they're like, I have been trying this and I cannot figure out how to get that. So that's really cool.
Yeah. This This, Tom, is a decade
Yeah, you've been working at this.
around the world teaching people short foot and
Yeah.
just really paying attention to how people respond. And like,
Hmm.
okay, when I word it that way, they seem to get it more. They don't get that. They connect to this. So there's like a
There's a
myriad
lot of years of
of
experience like coming into this.
yeah. But at its core,
Mm.
short foot, and this is even demonstrated in research, that short foot by far is the most effective foot exercise of any, from
Mm.
toe yoga, lifting toes, toe abduction, towel crunches, all of these short foot time and time again shows highest EMG activation, greatest hypertrophy of the intrinsics, greatest increase in toe flexor strength. So
Mm.
that's why it's really my go-to.
Yeah.
And the way that I teach it, just through what we were discussing, is very different than how Dr. Yanda.
Mm.
Dr.
Hmm.
Yanda is really the one who came up with short foot, and people can go to YouTube and actually find videos of Dr. Yanda teaching short foot.
Yeah.
He teaches it very different,
Mm.
where his is more stand, and then you're going to pull the met heads back towards the heel.
That's kind of what I've learned, I
Yep,
think.
which shortens the foot, hence the name
Yeah.
short foot. But and that's how I first started. But then I
Got
was
it.
like, okay, I'm dealing with high level athletes who are
Mm.
doing quick movements. When you jump and land,
Yeah.
like let's say you're doing box jumps, you cannot land on the box and then retract your met heads back.
Yeah.
That's not the action, right?
Totally.
So that's why I started looking at the fascial lines, and I was like, wait a minute, this is activating the deep front fascial line, which inserts on the bottom tips of your toes.
Hmm.
The action is in the digit. That's really where the cue has to be. So when I do quick cueing of short foot, it's toes in, like anchor your toes, toes, right? And every time your toes contract, you need to right?
Hmm.
So can you get the diaphragm to really drive that quick contraction as well?
That's so cool. Yeah. So you had a lot of you had quite did you have quite a bit of influence? You were talking about the which line did you say which fascial line? The deep front
Deep
line?
front. Yep, deep
Yeah,
front.
so Tom Myers' work and was that an influence in where you're coming at these things from? That kind of
Uh,
fascial work or
yes. So I use so anatomy trains I
yeah.
use as my alphabet,
Uh-huh.
is
Yeah.
what I consider it. And then I was very much influenced by Robert Schleip,
Hmm.
his work. So he's German. He
I don't
is
think I know him.
incredible. Oh, his textbooks, by far, I highly recommend reading. So
Hmm.
he's one of the founders of the World Fascia Congress. And everyone in the fascial space is very interconnected
Yeah.
because of this World Fascial Congress, and everyone's just trying to elevate the awareness of fascia. Tom Myers is great for establishing the language of these lines,
Got
right?
it.
So it's like, okay, when we say lateral line,
Hmm.
you and I know exactly what we're talking about, right?
Hmm.
Which muscles are part of that line.
Yes.
Then the utility or the application or the theory behind the movement of that line, I find becomes individualized, or yours is based off of how you look at human movement. I look
Hmm.
at it very different. Other people look at it a different way as well.
Yeah. Yeah. So cool. This is such a fun conversation. I want to be cognizant of your time, but I'm so glad we got to cover the short foot. I didn't even think that would come up, but I've seen a lot of research and talk out there about how important that exercise is. But again, this uh, I'm not a foot specialist like you are. So to hear how important that exercise is too, I'm so glad that the listener or viewer got to hear you kind of talk through how you teach that. That was such a cool element. I had no idea we would end up talking about. I wanted to just also, I know you've got so much on the teaching front. And how do you pronounce the name of your company? Naboso?
Naboso. Yep.
Naboso. How much time do you when you're spending a good deal of time each year teaching? Is it to patients? Is it to practitioners? Who attends those courses?
So it's primarily to professionals.
Yes,
So I speak a lot in podiatry, chiropractic, physical therapy, allied health, I guess, because there could be some massage, and then fitness and athletic performance. So all of those. So I try to wear a hat of injury prevention. That would be kind of the rehab side of it, right?
sure.
Let's
Yep.
say. But a large part of where my education is and how my mind thinks is performance based.
Mm.
So how can we get even more out of our hips, glutes, core, shoulder, torque, whatever it is? And that athletic side is really where a lot of my education is. So I
Hmm.
speak at 25 conferences a year,
Wow.
probably stuff like
Wow.
that. And to spread, I love it as an
Yeah.
educator.
Yeah.
Get it.
Yep.
Uh, and then, not unfortunately, but just it is what it is that a lot of my day now is being the CEO of Naboso. So
Hmm.
I spend a lot of time, thinking very executive function for the direction of the company
Got it.
and, what are the logistical demand plan side. That's just
Yeah.
the business side of
The
running a
business side. Yeah.
product. Yeah. But my brain is happy when it's developing products. We're
Hmm.
developing a couple new products. So I get to go into the,
That clinical kind of brain,
like,
like the
how do I
detective. Yeah.
connect here to here? And
Hmm.
maybe that's the forensic side of my brain.
Yeah,
That is very
totally.
satisfying. So,
Yep. I know a lot of people who were healthcare practitioners or maybe in the fitness space, like friends who have transitioned to more of the entrepreneurial business side. And I know a lot of times the like business parts sometimes are tough because it's like you just want to be doing the thing that you were successful in that got you to thinking about starting a business. So I'm sure sounds like you probably run into some of that.
yeah, definitely. It reminds me of think like you're a personal trainer and then you're like, you're so good. We're gonna make you the PT manager. And you're like, no, 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 this is
Yes,
not
totally.
fun. I want to be back
Exactly.
in the trenches doing it.
Totally.
So that's where I think it's good to obviously elevate because then
Yeah.
the message can be delivered to more people, or with our
Hmm.
products that can help people connect to their feet easier.
Yeah.
But that's why I still and I will always do some form of education and teaching in the conferences and
Yeah.
like that.
Yeah. That's amazing. Well, thank you so much for the time today. There's so much more. I have so many things I could keep asking you. So maybe we can do another episode down the road and look at specific diagnoses or just even hear more about kind of your model. Just so many other questions. But if people want to come find out more about your work, where would you send them?
Yeah, so on social media, I'm the functional foot doc. And then my website of where I see patients is thefunctionalfootdoc.com. As I had mentioned, I see patients in person or virtually, and most of my patients are virtually. It works great for almost all diagnoses. And then for Naboso that we happen to mention, that is naboso.com. That's the website for that. If anyone is into the education side and just curious on that aspect, because I do a lot of free webinars once a month, I do an educational webinar. That is ebfaglobal.com.
Okay, perfect. Well, thank you so much. Again, just thank you for the time, and maybe we can do a future one. I can pick your brain a little more, but yeah, thank you.
Thank you. I would love to be back, and there's a lot more to talk about.
Exactly, so much. All right, thanks. Have a good day.
Thank you.